Hello viewers, this is Dr. P. Mary Anupama. Today let us study about plasma proteins in health and disease. And mainly we'll be studying plasma proteins in health and disease. Here we have disorders of blood coagulation, that is hemophilia, sickle cell anemia and beta thalassemia. Hemophilias, these are genetically inherited disorders where the ability of the blood coagulation is impaired. It causes bleeding in people for longer duration in case of injury, bruises or even internal bleeding is seen. Hemophilias, these are of two types. We have type A hemophilias and type B. Type A is because of low amounts of the clotting factor 8, while type B is because of low levels of clotting factor 9. Both hemophilia A and B are genetic disorders of clotting factors 8 and 9 respectively. Factor 8 and 9 are either defective or made in insufficient amounts, resulting in impaired secondary hemostasis. The incidences of hemophilia A and B is about 1 in 5,000 males worldwide and affects individuals of all races and socio-economic groups. Classical hemophilia is hemophilia A and is estimated to account for about 85% of all cases, and half of these are caused by a variety of mutations in the gene coding for that factor. The second half of the cases are due to flip-tip inversion of factor 8 gene, resulting in misreading of a non-coding region and a shortened gene product. All individuals with this inversion have severe disease. Hemophilia B is also known as Christmas disease, is estimated to account for 15% of hemophilia cases. Genetics. Both genes, that is factor 8 and factor 9, they are located on X chromosome. This disease primarily affects males, but females are carriers and they may be asymptotic. Daughters of affected males, they are obligate carriers, and genetic counseling is recommended for families and individuals who are affected by hemophilia. 1/3 of hemophilia A is due to spontaneous mutations, and affected patients have no family history because it is a spontaneous mutation. However, all cases due to factor 8 inversions are inherited for a mother carrier. The risk that a mother of an affected male is a carrier of hemophilia A is about 80%. Coming to pathophysiology. Coagulation, it consists of two processes. We have primary and secondary hemostasis. Primary hemostasis involves the aggregation of platelets at the site of injury, while secondary hemostasis involves the coagulation cascade that leads to the formation of a stable fibrin clot. Factor 8 and factor 9 are both part of intrinsic activity of the coagulation cascade, and these factors, they convert factor 10 into factor 10A, and the step is the starting step for the common pathway. A deficiency or defect in factor 8 or factor 9, it decreases the activation of factor 10, resulting in factor 10A, it is impaired, and subsequent reactions necessary to create a fibrin clot, they are affected. So here if factor 10A is not formed, this 10A is going to activate prothrombin to thrombin, and then thrombin converts fibrinogen to fibrin and result in fibrin clot. If this is not there, then fibrin clot will be affected. Clinical presentations. There is a spectrum of disease severity among hemophiliacs. Severity is classified based upon the amount of factor 9 or factor 8 activity. So these are classified into severe, moderate and mild. In severe, coming to factor 8 or factor 9 activity, it is less than 1%, while in moderate it is just 1 to 5%, while here it is 6 to 30%. Frequency of cases are more, they are severe 50 to 70%, while here it is 30 to 40%, in moderate it is just 10%. Coming to the causes of bleeding, here it can be spontaneous, while in moderate it is minor trauma and rarely it is spontaneous, while in the case of mild it should be a major trauma that will cause bleeding, or during surgery it can cause bleeding. and the frequency of bleeding is more. It goes like this: 2 to 4 times per month, while here it is 4 to 6 times per year, while here the frequency of bleeding is very uncommon. And the pattern of bleeding, here at the joints, soft tissues, bleeding after circumcision, neonatal, all these cases. Here also the same thing. Here also the same thing. Any of these things can cause the bleeding. Here is the summary again. Normal hemophilia 50 to 150%, mild hemophilia 5 to 40%, and severe hemophilia is less than 1%. So here bleeding stops normally, while here bleeding can happen for no clear reasons. So once again a summary of the previous slide. Now some possible presentations and complications of the disease. The first thing is intracranial hemorrhage, ICH. It occurs in 2 to 5% of individuals and 50% of preterm infants with the disease. Half of the cases arise spontaneously and it can cause death among hemophiliacs. Prolonged bleeding after circumcision occurs in 30% of affected neonatals. Hematomas may occur following immunization. Oral bleeding during eruption of teeth can lead to anemia. Oral bleeding is not evident in infants because they swallow blood and we cannot see it in the case of infants. Delayed bleeding may occur after dental procedures or tooth loss, soft tissue bleeding, all these things we can see. Large intramuscular hematomas may occur. Muscles may become swollen, hard and painful. May present as acute abdomen neuropathy or compartment syndrome. Joint pains due to hemarthrosis can lead to hemophiliac arthropathy. Patients often have a target joint that is the site of recurrent bleeding episodes. Other presentations include spontaneous hematuria, where you find urine in the blood in the urine, and menorrhagia, that is during menstrual cycle. Prenatal genetic testing should be offered to all known carriers of hemophilia gene. Next we have this chorionic villus. Sampling is offered between 9 to 11 weeks of gestation. That is how we go for testing. Or amniocentesis can be done. It is offered between 12 to 15 weeks of gestation. Treatment. Management of hemophilia requires prevention and treatment of acute bleeding episodes. Acute bleeding episodes are treated with clotting factors. Patients, they often have a sense that they are bleeding. They may feel a trickling sensation, warmth or tingling sensation from blood accumulating in tissues. Prophylaxis, it involves comprehensive care team of physicians, specialists, dentists, genetic counselors, physical therapists, occupational therapists and nurse coordinators. Sickle cell anemia, also called as sickle cell disease, is a serious group of conditions which are inherited, that is they are genetic. It affects the RBC in the blood. In case of sickle cell anemia, the name is given because of the specific form in which you can see there are two sickle cell genes that would make the cells to change their shape. So here the RBC they are rounded, but because of these genes they become sickle shaped, like the normal crescent shape instead of disc shape. So this is the microscopic observation which shows that the person is affected with this sickle cell disease. There aren't much RBC to carry oxygen in these individuals to meet the body needs. Normally the flexible round RBC move easily through the blood vessels. But in sickle cell anemia, the red blood cells, they have lost their shape and they become sickle shaped or crescent moon shaped. These cells, they are rigid, sticky and get stuck to small blood vessels, which can slow or block blood flow and oxygen transport to parts of the body. There is no cure for most people with sickle cell anemia, but treatments can relieve pain and help prevent complications associated with the disease. So this is the normal blood blood cells are the RBC, and they easily squeeze through the blood vessels. While the sickle shaped cells, these RBC, they block the passages, obstructing the oxygen carrying capacity. So the blood loses its oxygen carrying capacity, and here you can see the shape. Abnormal hemoglobin forms strands that curve the RBC like this, while this is the normal hemoglobin which gives it a disc shape. This is the half of the disc shape RBC. The signs and symptoms of this particular sickle cell disease, they appear in around 5 months of age and they vary from person to person and they can change over time. So here you can see it can lead to anemia. Sickle cells, they break apart easily and die in less than 10 to 20 days, and this leaves a shortage of RBC that results in anemia. So without enough RBC, there is no sufficient uh, red blood count available, hence it leads to fatigue. Second symptom is episodes of pain. Periodic episodes of pain is seen as sickle shaped RBCs block blood flow through tiny blood vessels of chest, abdomen, joints. Pain can also occur in bones too. The intensity of the pain, it varies and it can last from few hours to even few weeks. Some people have only few pain crunches a year. Others have dozens or more pain crunches per year. A severe pain crisis requires a hospital stay. Some adolescents and adults with sickle cell anemia also have chronic pain, which can result from bone and joint damage, ulcers, and other causes. The other symptoms that we see include swellings of hands and feet due to blockage of blood vessels, then frequent infections because sickle cells, they can damage spleen also, hence people are more vulnerable to infections. Delayed growth or puberty, this is due to shortage of oxygen and nutrients required for growth, leading to delayed puberty in teenagers. Then they may have vision problems because tiny blood vessels that supply oxygen to the eyes, they can get plugged with the sickle cells. This can damage the retina and the portion of the eye that process visual image is damaged, and this can lead to vision problems too. Then genetics. Normally humans with hemoglobin A, it consists of 2 alpha and 2 beta chains. Hemoglobin A2, it consists of 2 alpha and 2 delta chains. Hemoglobin F, it consists of 2 alpha and 2 gamma chains. Of these three types, hemoglobin F dominates until about 6 weeks of age, followed by hemoglobin A, which dominates throughout the life. In this disorder, at least one of the beta globulin subunit in hemoglobin A is replaced with what is known as hemoglobin S. The gene defect is a single nucleotide mutation. So we have GAG, which is changing to GTG of the beta globulin gene, that results in substitution of valine instead of glutamine at position 6 on the P arm of chromosome 11. So mutation is leading to 1 point mutation is leading to a change in one amino acid. So here we can see glutamic acid is replaced by valine at the 6th position. This is the HbA, while this is the sickle cell hemoglobin. And the pattern of inheritance, it is an autosomal recessive disorder. Say this is the unaffected carrier and the unaffected carrier mother. Both of them are carriers. So heterozygosity is there in both. So here we have, there is 1 in 4 chance that an unaffected child will be born, while there is 50-50 chance that we can get a carrier, or again there is 1 in a chance that you totally get an affected carrier. This is because of the pattern of inheritance. So if it is totally RR, that is it is causing normal hemoglobin to come, while as this is a recessive one. And if both the genes, autosomal genes, on the X, if both the X chromosome genes have this recessive one, it will be expressed. Finally, the offspring is affected. Other complications. This can result in stroke because the sickle cells, they block blood flow to an area of the brain, leading to seizures, weakness, numbness in the arms, legs, sudden speech difficulties, and loss of consciousness. People can get acute chest syndrome, that is a lung infection resulting in chest pain, fever, difficulty in breathing. People also get pulmonary hypertension, that is people with sickle cell anemia, they can develop high blood pressure in their lungs, leading to shortness of breath and fatigue. It can also damage organs. This is due to the decrease in the blood flow. So lack of oxygen rich blood can damage the nerves and organs including kidneys, liver, spleen, and this can be fatal. It also can lead to blindness, leg ulcers, gallstones, pregnancy complications, so on and so forth. So what is the prevention? First thing is genetic counseling. Next one have to take the preventive measures, and then people have to choose, if they are carriers they have to choose reproductive options. Next is thalassemia. Thalassemias, these are heterogeneous group of hereditary blood disorders which are characterized by faulty globin chain synthesis resulting in defective hemoglobin. This can lead to anemia. Based on the defective globin chain, these are either classified as alpha or beta subtypes. These are more frequent in areas where malaria is endemic. Alpha thalassemias, they occur most commonly in patients of Asia or Africa origin, while beta thalassemia is predominant in patients of Mediterranean descent. Beta thalassemia can be further divided into heterozygous minor and homozygous major variant. Minor variant features has low risk of hemolysis. Major variant presents with severe anemia as well as infancy and often causes growth retardation. Severity in alpha thalassemias also varies due to deletion of genes. Anemia generally first arising with the deletion of 3 of the 4 alleles, and this leads to HPH disease. Deletion of all 4 alpha globin alleles, which is the HB bar disease, is fatal in utero or shortly after birth. In all forms of thalassemia, insufficient erythropoiesis will be taking place, and this can lead to extramedullary hematopoiesis as well as bone marrow hyperplasia. Here extra bone marrow tissues, they start doing this hemopoiesis and bone marrow accumulates hemopoietic cells. Diagnosis is confirmed via electrophoresis or DNA analysis, and patients with thalassemia, they require transfusion therapy and causes a gene mutation. In beta thalassemia, usually this is due to point mutation in the promoter sequence or splicing sites of beta gene locus, short arm of chromosome 11. It is located in the short arm of chromosome 11. Alpha thalassemia usually is due to deletion of at least 1 out of the 4 existing alleles. The inheritance pattern is autosomal recessive. And pathophysiology, normal adult hemoglobin HbA is composed of 4 protein chains, that is they have 2 alpha and 2 beta globin chains arranged in a heterotetramer. In thalassemia, patients have defects in either the alpha or beta globin chain, causing the production of abnormal RBC. The thalassemias they are classified according to which chain of hemoglobin molecule is affected. So we have alpha thalassemia wherein the production of alpha globin chain is affected, while in the case of beta thalassemia, production of beta globin chain is affected. The beta globin chains they are encoded by a single gene on chromosome 11, while alpha globin chain are encoded by two closely linked genes on chromosome 16. Thus, in a normal person with two copies of the chromosome, two loci encode the beta chain and four loci encode the alpha chain, and deletion of one of the alpha loci leads to alpha thalassemia. Beta chain point mutations in promoter sequences or splicing sites of the beta globin locus on the short arm of chromosome 11 leads to beta thalassemia. Symptoms include silent carriers are asymptotic, while alpha thalassemia traits are mild hemolytic anemia, hemoglobin H disease, it results in jaundice and anemia at birth. Hepatosplenomegaly is seen in this. Then skeletal deformalities, these are less common of course. And incompatible with life, like you may see death in utero itself or immediately after the birth they may die. And laboratory tests, here they collect the blood samples and do the tests. Blood samples where the patients with thalassemia minor or thalassemia trait usually have a normal red cell distribution width and a higher RBC. Hemoglobin is less than 10 grams per deciliter. Signs of hemolysis is decrease in hepatoglobin, increase in LDH, that is lactate dehydrogenase, increase in indirect bilirubin, increase in reticulocytes, all these are the signs. So they can prepare blood smear, the target cells, they can do this teardrop test, and bone marrow biopsy also can be done. They get this reactive hyperplasia indicating thalassemia. And confirmatory tests, the hemoglobin electrophoresis, they do what? Alpha thalassemia can usually be detected if more than 1 in 3 alleles are defective, and abnormal patterns they depend on the exact subtype. And DNA analysis, this is done to test alpha thalassemia minor and minima also if it is less than 3 alleles are defective. Thank you for watching this video. See you in our next video.